Hello, today we can discuss about WHO-Partograph. Why WHO-Partograph? What is the importance of WHO-Partograph? How can it help you? What is the relevance? And this is my profile. I am Dr. Jeeja Beacom from Kerala Health Service. I dedicate my talk to my teacher, Dr. N. Shamala, who was my professor while I doing PG at Trivandrum Medical College. So let us come to the history of partography. It was in 1955 that Emanuel Friedman from New York, he was the one who introduced partogram. Why he introduced? Because in some remote areas like Africa, it was in Africa really the partograph started. Here they need to travel so many kilometers far to reach a hospital for operative deliveries and all. And the midwives were the one who were attending to the patients. And Friedman thought that they need some help. And in his partogram, he only recorded about cervical dilatation to the time. This is a graph. Partos means related to parturition. Parturition is something related to labor. So, partos and graph. Graph, as you know, a graph will have an x-axis as well as a y-axis. Here in x-axis, Friedman plotted time, and in y-axis he plotted cervical dilatation. That was in 1955, but it didn't catch up. Later, 1972, Filfort and Castle, he modified this partograph. They added two more lines. They found that just cervical dilatation to the time is not relevant, and some other factors also are there. And the head has to. You will have to consider the fetus, the descent of the fetus. Then also after considering the descent and cervical dilatation, the staff should be aware of when you will have to take action, when you will have to be aware of. So they introduced two lines, alert line and action line, which I will give you in detail. Then in 1994, the WHO took over the task. They conducted trials in some developing countries like Thailand, Malaysia, Indonesia, and they came out with a composite partogram. Here they introduced the latent phase. Latent phase was already there in Friedman's partograph, but they gave some importance to the latent phase also. Along with that, they introduced the active phase, which started from 3 centimeters dilatation of the cervix. That is in 1994 when WHO took the first task. In 2000, again the modification came. They found that the latent phase was not that relevant because once you have to consider the latent phase, it should be not more than 8 hours. And most of the patients, they enter the labor room 2 days prior to with false labor pains, and finally this part of the partogram was removed. Then the alert line, they started from the 4 centimeter point. Initially it was 3 centimeters, now they started from the 4 centimeters. And here the demerits, that false labor can't be ruled out, and the time of transfer. Mainly the partogram is taken to consider when the proper action to be taken in remote areas, when the patient has to be transferred to a tertiary center for better care. So these factors could not be taken care of. In 2006, they came out with the color-coded partogram, which would be easy for the health workers, but it also didn't catch up. And finally, in 2008, WHO partogram modifications, which we still follow and which carries in most of our hospital case sheets, are introduced, and that has to be floated out. Here, this also latent phase is removed, active phase starts at 4 centimeters, and in the active phase, cervical dilatation is considered per hour 1 centimeters dilatation. And this WHO partograph in 2008 has 4 parts. There's the patient information part, fetal conditions, then the progress of labor, and the maternal part. Here is the detailed WHO partogram, which is still followed. And what are the patient identification points? See, here you can see you will have to fill the name of the patient, gravida, parity, hospital IP number, date of admission, the time of admission, the time of rupture of membranes, and also you will have to enter the institution part. That is the general information. Next comes the fetal part. Fetal part, fetal part has got the fetal heart rate monitoring part, then the color of the liquor, then the molding of the fetal skull bones. I shall give you the detail later. And the fetal heart rate part, you have to monitor every 30 minutes in the latent phase, every 15 minutes in the active phase, and every 5 minutes in the second stage of labor. 15 minutes in the active phase means every 15 minutes after 4 centimeters dilatation. And the active second stage of labor, there is in each and every contraction, after each and every contraction, there is chance for the fetal heart rate to go down. So it's important to monitor the fetal heart rate after each and every contraction. Ideally, 5 minutes is considered. And the first part every 30 minutes in the latent phase is usually not recorded now. And it is plotted in the graph as dots which are joined later. And importance of fetal heart rate is, normally the fetal heart rate is taken between 110 per minute to 160 per minute. If it's less than 110, it is fetal bradycardia. If it's more than 160, it's fetal tachycardia. And if it's less than 100, it is severe bradycardia. And next column comes the membrane and the amniotic fluid column. Here, if it is intact membrane, it is written as I. If absent liquor, it is written as A. If clear mature liquor is written as C. And if it's meconium stained, it's written as M. And if it's blood stained as abruptio placenta or placenta previa, you can, or other conditions in traumatic and all, you can write as B. See, you can see the plotting there. Fetal heart rate, it's monitored from 140 every half minute, every half an hour, it's plotted. It's coming finally to 90. At the time when it reaches 90, it is meconium state, it's written as M. You can see the amniotic fluid column, it's written as M. And next comes the molding. Why molding? The fetal skull is made up of a number of bones which are divided by sutures, and these bones only fuse after birth. This is to allow, why is the purpose? It's because it should allow the fetal skull to pass the maternal pelvis. And the skull bones goes on overlapping during delivery to decrease the diameter of the fetal skull, and the overlapping of the bone is termed as molding. In short, molding allows the pelvis to accommodate the fetal skull. This is how we have to do the grading. That is 0 if the bones of the skull are separate. It has separate sutures. You can feel the sutures. +1 when the bones are approximating each other. +2 the bones are overlapping but they are separable. And +3 they are overlapping and could not be separated. In +3 you considered it as cephalopelvic disproportion. This is how we do the fetal part monitoring. And wide importance of fetal heart monitoring. If deceleration is less than 100 or less than 110, you get continuously you get 3 decelerations. It is indicative of emergency termination. Now, in the next part is the progress of the labor part. It has got 4 parts: cervical dilatation, descent of the fetal head, and uterine contractions. Now, let me talk a bit about the alert line and action line. Alert line C, it starts from 4 centimeters dilatation. That is the 0 hour you plot the graph. 4 centimeters when the patient is having cervical dilatation of 4 centimeters. And you consider hourly dilatation of 1 centimeter. And so, the alert line C, it starts from 4 centimeters. Hourly dilatation you mark, and finally it reaches the 10 centimeter position. You can see the slanting line over there. And next the action line is plotted 4 hours after the alert line. It is parallel to the alert line, action line. So, alert line means you have to be alert if the patient will go for delivery or any other complications developing, just to give an alert to the health staff. Then the action line, when the graph crosses the action line, it is time to take action. So, the alert line is called health facility line. And then the action line is the decision taking line or the hospital line. This is how the cervical dilatation is plotted. At 4 centimeters start the alert line, hourly monitoring, and finally reaching the 10 centimeter point. Then the action line, it's 4 hours away from the alert line. It is parallel to the alert line. Action line is parallel to the alert line. See the cervical on the y-axis you are plotting the cervical dilatation centimeters, which is plotted as X. And then comes the descent of the head minus from 5 to 0 it's plotted as O, and the hours is marked, 24 hours are marked. Here it's only shown 12, but 24 hours are marked in the x-axis. This is what I told earlier, dilatation from 1 to 10 and each square 1 centimeter dilatation, it's plotted as x. This picture shows the cervical effacement and dilatation. See the initial picture A. In A, the cervix is not at all effaced and the whole length of the cervical canal is 4 centimeters. And then it's partially getting effaced. See the taking up of the cervix. The cervix is pulled up and the length of the cervix is half, 2 centimeters. Then the cervix is almost fully taken up, that is fully effaced, and then the cervix starts to dilate, and the picture D shows 3 centimeters dilatation of cervix and picture E shows 8 centimeters dilatation of the cervix. This is the descent of the head. Per abdomen, you have to palpate the fetal head. How much fifth of your fingers can accommodate the fetal head? That is just above the pubic symphysis. In the first picture, you can see 5/5 is palpable. All 5 fingers can palpate the fetal head. Then it goes down. The line shown is just the pubic symphysis brim, pelvic brim. Then see the head is descending gradually, and finally almost see first picture 5/5, then 4/5, 3/5, 2/5, 1/5 and 0/5. 0/5 is fetal skull has reached up to the ischial spine, that is it is getting engaged. That is what you plot on the left hand side of the graph. That's the descent of the head, which is plotted as O. In this picture, you can palpate you are doing the pervaginal examination and you are palpating the ischial spine. Spines are palpable on both sides of the pelvis. That's the most prominent part on lateral wall of the pelvis is the ischial spine. When the head of the fetus reaches the ischial spine, that is serostation. This is how you see the descent. See the first picture shows the head is mobile, it's above the brim. Second is getting engaged. Parallel to on the right, the other side, the head accommodating the full width of the 5 fingers above the pelvic brim, 5/5. Then the last picture on the corner is head is 2/5 width above the pelvic brim, that is written as 2/5. Engaged is 0/5. Okay, now you can monitor the contractions. Contractions you have monitored in every 10 minutes how much contractions you are getting and the duration of the contraction. That is less than, it is taken as contractions less than 20 seconds, 20 to 40 seconds and more than 40 seconds. Less than 20 seconds you plot as dots. Then 20 to 40 seconds you plot as stripes, and more than 40 seconds you darken the space, and each space denotes one contraction, and there are 5 columns, that is in 10 minutes how much contractions you are getting. So in the first column, see there are 2 columns which are plotted as dots, that is 2 contractions each lasting less than 20 seconds. Then you have 3 columns, that is 3 contractions each lasting less than 20 seconds. Next you can see the stripes, that is first column is 3, the next column is 4, that is 20 to 40 second contractions, that is 4 contractions you are getting. And the last column, every 5 columns are darkened, that 5 contractions you are getting and lasting for more than 40 seconds. Then comes below that is the maternal part. In this part, you have columns for plotting for oxytocin drip, how much units and how many drops. Then below that, there are columns for the drugs given like antibiotics or sedation, anything, and IV fluids. And below that, you have to monitor the maternal conditions like pulse rate every 30 minutes. You have to plot as dots. BP, diastolic and systolic BP as vertical lines you are plotting, that is recorded every 4 hours. Then you can record the temperature every 2 hours, and whenever the patient passes urine, you have to do the oleum, you have to calculate the oleum as well as analyze the protein and acetone content. This is how we do the marking, the maternal part. So, see, it contains, see the maternal part having the drugs, pulse rate, BP, temperature, urine. See, so now you are completed with the plotings on the partogram. So who should plot the partogram? It can be a staff nurse, it can be a midwife, it can be a doctor, any health staff can record. But though that person who is recording, a single person should the complete monitoring. And he can hand over to the next duty staff with the partogram regarding the progress, and the next person can continue with the partography. So there is a uniformity. So ideally, in one health worker who monitors the lady should enter the information until the patient delivers. See the midwives or staff nurse, somebody, health worker recording the partograph. And when you have to start the partography plotting, I said that according to the 2008 WHO partograph, it is at 4 centimeters dilatation you start the partograph recording. Even if the patient comes in contraction, she is not at reached 4 centimeters dilatation, you need not start recording. So at 4 centimeters we start the recording with getting regular contractions. That we consider as active phase of labor. This partograph recording, you can see first it begin plotting at 0 over, that is 0 over is 4 centimeters dilatation. See, the all entries are made in relation to the time when the observations are made, and the note should be legible, should be dated and should be timed. And finally in a column, you can see on the right hand side, in a column, the outcome is written. That is spontaneous vaginal delivery, at what time, what sex of the baby, and what is the weight of the baby. Then completes the partograph recording. Again, once more, I am showing the partograph. See the general patient information, fetal part with fetal heart rate, amniotic fluid coloring, molding, then the progress of labor, that's dilatation of cervix, descent of the head, alert line, action line, time, then the contraction, the number of contractions, if it's less or if it's active or strong contractions, oxytocin drip in units and drops, drugs given, IV fluid, maternal part, pulse, BP, temperature, and the urine. So what is the advantage of partography? The partography has a predictive value. You are able to estimate the expected time of delivery if the labor progresses normally. And in dysfunctional labor, it serves in warning of the impending problem when you have to interfere. Delay in labor can be detected early, and timely correction or timely intervention is possible. What are the objective records? I have said that it has got very important legal importance. There is a uniformity in recording. It's a straightforward record of all the events of labor which can be seen at a glance, and easy to hand over the duty from staff to staff. And is of statistical analysis. It's also important. Medical legal, I said that in legal aspect only this page of the case sheet is very important, and you can make decision in transferring the patient to a tertiary center. Now latest e-partography has come into play. There are apps in which can be downloaded in the mobile apparatus, mobile telephones, and the midwife can record the staff nurse, even if the medical officer is not in place, they can record the changes, all the recordings aptly, and timely real-time transfer to the duty doctor is possible, and decision can be taken. Poor utilization. For recording a partograph, you need training, and also you need the follow-up. You should know what you are recording, and you should know how to interpret. So if it's not properly recorded, it shows that the monitoring of the mother in labor is very poor, and poor utilization reflects poor monitoring of the mother in labor and poor pregnancy outcome. Why is it important to record the progress? Documentation is very important. Provide continuity of care. I said that uniformity between staff to staff. To provide a basis of decision making, it's important. Research purpose, audit purpose, and to defend one's action. You can say that I have monitored the patient. It's very much evident on the recordings. If you have not documented, you don't get any defense. There are studies being conducted. See, the conclusion says that this study shows that using a partograph improves the quality of delivery care, since it permits to identify dystocia, make logical and effective interventions, and reduces unnecessary strain on mothers by reducing total duration of labor without any increased fetal morbidity or mortality, and if accepted as a routine procedure, it will be suitable in all situations where the labor room remains busy and congested day and night for better and more efficient management of delivery. See, once more I have given the partogram recording. It should be legible, dated, time. You can record the outcome of the delivery also. From this single sheet, the whole procedure in the hospital to admission to discharge is evident. Now we can see some of the examples of partograph recording. See, the patient came in, the 0 hour recording starts at 5 centimeters. At 5 centimeters plus 3, head is 3/5 palpable. Then once the labor is progressing normally, the recording should be either parallel to the alert line or towards the left side of the alert line. Once it crosses the alert line, you should be careful. Here you can see the recording is lying on the alert line. Fetal heart rate is normally monitored 130 to 140, 150 ranging, below 160. Clear mature Liker. The dilatation of cervix and the descent of the head is normally progressing, and at 0 hours for it was 5 centimeters I said, and the descent of the head after 1, 2, 3, 4, 5 hours, the baby is being delivered. That strong contractions throughout labor time. BP, pulse rate recordings are all normal, and the outcome has also been monitored. It's written over there. See this chart here. She got admitted at 10 a.m. Dilatation is 4 centimeters. It's at the tip of the alert line. Membranes were intact. It's written as I. Fetal heart rate is on 40. Molding is not yet mentioned. Head is 5/5 palpable. That is at 0 hours. 4 hours later, dilatation is still remaining 4 centimeters. Head is still 5/5 palpable. And then the membranes were ruptured. R it's written, membranes ruptured. Then comes clear Liker. After 4 hours, again she is monitored. Dilatation from 4 to 6 centimeters. But the head is still at 5/5 palpable. It's not descended. Head is still not descended. But cervix dilatation 4 to 6. That is, there is some dilatation over there. Clear mature Liker. Fetal heart rate has reached 110 now. Then it's descending. It's reached up to 90. Meconium staining. And the decision was taken after 11 hours of monitoring. See, below the contractions are monitored. It's just dot support. Less than 20 seconds contractions are only there. No active contraction. In the topmost part, you can see time of admission 10 a.m. and rupture of membranes at 13:30 hours. What is secondary arrest of cervical dilatation? When the cervical dilatation commences normally but stops or slows down significantly for 2 hours or more prior to full dilatation of cervix. That is, when cervical dilatation progressing normally but it stops, or either stops or it slows down significantly for 2 hours. It's not getting progressed for 2 hours or more prior to full dilatation of cervix. Full dilatation cervix is not taking place. That is secondary arrest of dilatation. Now secondary arrest of head descent. Abnormal progress of labor can occur with normal progress of descent of fetal head, then followed by secondary arrest of descent. Head is descending, but it can be stuck at some other position and no further descent. That is secondary arrest of head descent. Two other terminologies to be aware of. And this chart, again, example 3, she got admitted at 10 a.m. At 10 a.m. she is 4 centimeters dilatation. After 4 hours, she is 6 centimeters dilatation. Here the descent of the head is it's 3/5 palpable. At the end of 4 hours, it's still 3/5 palpable. Membranes were ruptured. Clear Liker. Fetal heart rate progressing up to 130, 140 range. She is getting 20 to 40 seconds contractions. Then at the end of 4 hours, she started getting active contraction. but the dilatation is, it has crossed the action line. Dilatation is still 4 centimeters, 6 centimeters, and the descent of the head not yet taken 3/5 palpable, and the decision was taken at end of 8 hours of admission, that is at 17:30 hours, and the baby was 4.6 kg baby. See this chart. Here she got admitted at 10 a.m. At 10 a.m. the dilatation was 4 centimeters. Head was 5/5 palpable with intact membrane, fetal heart rate 140 centimeters with mild contraction, that is less than 20-second contraction. And after, here the next plotting is done after 2 hours. Here same findings were there. Then after 2 more hours, again the findings, they see that 5 centimeters dilatation, but the descent of the head is still 5/5 palpable, no descent of the head. At that time, she got membranes ruptured, artificial rupture of membrane, ARM done at the end of 4 hours, clear mature like a heart rate is 130, and the contractions 20 to 40 seconds. At this rate of contraction, the head start descending, and she was started on Pitocin drip. After ARM, she was started on oxytocin drip. Gradually, the contractions are progressive. That is, the second recording, it was almost nearing the action line. So now it's indicative you have to take action. And so the acceleration with Pitocin and the labor progress. Finally she delivered. See the head descent reaching below at 0 station, and the full dilatation is reaching 10 centimeters. That is augmentation of labor. That is the importance of action line. Once the recording nearing the action line, it is time to intervene. Now the latest advancement of Partograph has come out recently. It is called the WHO Labor Guide. Recording is there, but it's not still accepted. Controversies are going on. So from this, you can understand that Partograph is a close friend. It's a companion. It can never cheat us. But once you cheat the Partograph, it can also cheat us, and we are in trouble. So let's hope that it will be of use for you. Thank you.